Hello everyone, this is Harkirat Bal. Welcome back. Today I'm going to lecture on a very important and sensitive topic, mood disorders. In my opinion, you're going to see this topic a lot throughout your career during clinical practice and beyond. I am going to divide this lecture into two parts. In part one, we'll focus on a client who's depressed, something that we call unipolar depression. And then after that, we'll take a quick bio break. Then when you come back in part two, we will focus on a client who is on the other pole of the mood spectrum. Maybe going through a client who's going through mania or hypomania, something that we call a bipolar disorder. I am not going to lie, this is going to be a long lecture, so I highly recommend whenever you get tired, please make sure you pause, take a quick bio break, and don't forget to take good notes along the way. All right, so let's get started. Before I really get into in depth of mood disorders, let me ask you this question. What type of advice do you think people give when their friends or family members report to them that, oh, I think I'm having a bad day, or I think I'm depressed, I think I'm sad, I think I'm nervous, anxious? What type of advice does the society give to these clients? I'm not talking about medical professionals here. I'm not talking about you or healthcare providers. I'm talking about in general, like your cousins, your friends. I don't know about you, but I have heard people saying, "Oh, come on, be positive," or it's all in your head. I have heard people saying you'll snap out of it, like you have a control over it. Yeah, I have also heard people saying time heals all wound. Needless to say, these are non-therapeutic communication skills. This is not how, as a healthcare provider, we should be talking to our patients. And I know you don't, because you know better. I have heard people saying, think of people who are worse than you, and that's not nice. When somebody is having a bad day, we should not tell them, well, there are other people who are worse than you. That's not going to help. You're actually minimizing their concerns at that time. And I have also heard this before. Come on, you're a man, and men don't cry. This actually further creates a stigma. There are some culture where as a man, you do not feel comfortable expressing yourself, your feelings. So I hope moving forward, we learn a lesson, and we should never ever tell people. We know better that depression or anxiety, bipolar, or any disorder for that matter, does not discriminate. It doesn't care if you're a man or a woman, or your ethnicity. It doesn't matter. Up to some degree, we all are at risk for these kind of issues. And I have also heard, don't you believe in God? People who believe in God don't get depressed. Now, and I know it's very sensitive statement, and some people firmly believe in that, and I respect that, by the way. There are people who have a very strong faith, and some people are spiritual, and I respect that. However, from a scientific standpoint of view, we really don't have a study or any evidence that if you have a group of people who believe in God, they do not get some kind of a mental illness. We don't have that data. What we do have is, though, there are many studies done that people who have some degree of faith, people who are spiritual, they heal better, they recover better. So there is a component of prayers and spirituality, and I respect that, of course. But the message here is, um, you can be spiritual, you may believe in God and still at risk of getting depression, and it's okay to ask for help. It's okay to acknowledge that you may recover better and quicker and smoother than your cohort. So we have to be very, very careful when we talk to our patient or clients regarding this. Okay, well, first of all, I apologize for such a small font, and the reason is that I needed the space on the right hand side to draw something. What I'm going to do is I'm going to introduce some terminology that I believe will set the stage, that will really help us to understand the rest of the lecture. So what I'm going to do is I'm going to draw a straight line here, and I'm gonna put a dot in the middle, and I'm going to call that as normal. Normal, and it's a normal mood. So what I'm going to do is I'm going to give you variations in mood, trying to help you what is normal versus pathology. At the same time, please understand there's no such thing called being normal. I always tell my patients that normal is just a setting on a washing machine. In real life, there's no such thing called normal. Everything is on a spectrum, if you will, right? So I really cannot define a normal or a neutral mood. At the same time, let's pretend that this dot in the middle is normal. The term that we use for a normal mood is euthymia. So that's a Greek word, like a euthyroidism, like a normal thyroid. It's not a hyper or not hypo, so it's a normal. So euthymic. Okay, now please understand that anytime we have small variations of a mood, that is not a pathology. For example, when we see something good, when we hear a good news, we feel good, we feel happy, we get excited, and that's a good thing. For example, if I saw a bird flying or a fish swimming or some stars at nighttime, I feel good, I love it. So my mood is gonna be, slightly shifted from being neutral or normal to something that I'll call happy. So it's feeling happy is a good thing, happiness. Okay, that's a small variation, but unfortunately, or maybe fortunately, I don't know, nobody stays in happy state forever. So pendulum will come back to normal state. Now the opposite is also true. When we hear a bad news or a sad news, we feel bad, we feel sad. So for example, if I see a dead bird, or somebody got sick, somebody got injured, something bad happened, then we feel sad. Feeling sad is also considered normal variation. It is not a pathology. As a matter of fact, we actually expect people to react appropriately to the news, either happy or sad. So again, fortunately, nobody stays in this state forever. People usually come back to normal state, and a pendulum keeps swinging back and forth on any given day. We feel good, we feel bad, and that's normal part of life, normal variation. This is physiology, nothing wrong. This is not a pathophysiology. Now, the pathophysiology is when from feeling sad, we were supposed to go back to the normal state. However, pendulum keeps swinging, and we are at another stop, and we'll call that depression, major depressive disorder, let's say. And it's been more than 2 weeks. More than 2 weeks will be depression. Now, please understand, this is not the entire criteria for MDD. We'll talk more about DSM criteria in depth, but at this time, just keep one thing in mind, and that is a timeline. More than 2 weeks, symptoms are present. Needless to say, you would have to have some other symptoms and impact on the ADLs, right? But we are not talking about that yet. Now, what if instead of feeling better, pendulum keeps swinging up, and we are at a last stop here, and we will call that persistent depressive disorder, and the time frame now is more than 2 years. More than 2 years, and that is your persistent and depressive disorder. Now, on the opposite side, when you have a client who is happy, excited, but the symptoms continue this way, and we will call this hypomania. In a few minutes, I'll give you the definitions, but let's call that hypomania here. Okay. And then instead of pendulum coming back to the normal state, if it keeps going this way, and on top we will have mania. Now the main difference between hypomania and mania is that the symptoms for hypomania are present for at least 4 consecutive days, whereas for mania, symptoms are present for at least 1 week, 1 week or more. However, if you have a patient who's hospitalized and symptoms are present, even if day number 1, day number 2, it's less than 1 week when the patient is hospitalized, we'll call that mania. All right, so let's come up with, give me 1 second here, let me change the color. Let's understand some differences here. When you have a client on this side of the curve, if the pendulum is swinging to feeling sad and depression and persistent depressive, we'll call this as unipolar depressive, unipolar depression, you can say, right? Because it's just on the one side. However, if you have a client who at one point was depressed and now you have symptoms of mania, then we call that a bipolar. Okay, bipolar depression or bipolar depressive disorder. If symptoms are at hypomanic phase, we will call that bipolar 2. If you have a client with mania, we'll call that bipolar disorder 1. So the difference between 1 and 2 is whether or not you have a mania or hypomania. And we will talk about this concept in depth in a few minutes. When you have a client who's going back and forth from unipolar to mania and back and forth, we call that cycling or rapid cycling. Okay, so what if you have a client who's not meeting the criteria for a major depressive disorder and or not meeting the criteria for mania or hypomania, but you do have a patient who has some symptoms, you know, the patient is reporting depression, if you will, and the term we use for that setting is cyclothymic disorder. So we can give a diagnosis of a cyclothymic disorder instead of a bipolar. So if you have a client who's adult and they have symptoms for more than 2 years, or you have a child with a symptom that lasts for at least 1 year, what are these symptoms? Well, both a hypomanic and depressive period without meeting the complete criteria for either mania, hypomania, or major depressive disorder. And I'll make that point again when I talk about a bipolar disorder in a few minutes. Then you have a situation where we have a postpartum depression. This has nothing to do with the bipolar. This is a separate. So the symptoms are present within 4 weeks after the birth of a baby. It is believed to be due to hormonal imbalance such as estrogen, progesterone, prolactin, and so forth. And we will talk more about women's health, and so forth in next semester. Neurosis is a term that we use when you have a client who still has some in touch with reality. They are not disoriented. They understand what's going on. They're still alert and oriented times 4, if you will. For example, you may have a client who has anxiety, depression, or OCD, but they understand that they have depression. They understand that they have OCD. They have not lost contact with the reality. So in other words, it's a depression. It's not a depression with this psychotic features, However, if you have a client who lose contact with the reality, such as in the setting of schizophrenia, we call that psychosis. So these two terms are simply telling me that you have a client with the first one, you have a client with some mental illness, but they understand that they have that illness. Whereas with the psychosis, they do not understand that they have these symptoms. As a matter of fact, well, as you know, when you have a client going through psychosis, such as hallucination or paranoia, they firmly believe in those symptoms, right? And again, we will talk more about psychosis in a separate lecture. Okay, I know this slide is very, very blurry. I do apologize for that. But what I'm trying to tell you here is that be careful the way we talk to our patients. Words do matter. So instead of saying, a client is suicidal, make sure we say that a client who has a suicidal ideations, or instead of saying a client is a schizophrenic, maybe we can say a client who has schizophrenia. One way to always double check or triple check if the way you're talking to a client is sensitive enough or professional is to replace the whatever disorder you're going to use, replace that with a cancer, and with the term cancer, and see if that makes sense. For example, would you ever say to your client that you are cancerous, or this client is cancerous? The answer is no, we will never say that. So if we don't say a client is cancerous, we should not say that this client is delusional, or this client is schizophrenic or suicidal. What we should say is this client has a cancer, a type, whatever the type of cancer that is, right? This client has a breast cancer or a prostate cancer, whatever. Same thing here. We can say this client has depression. This client has drug use or substance use, or whatever, if you know the name of the substance use disorder, instead of saying this client is drug user or abuser. We don't use those terms. So be very, very careful as a mental health professionals. Words do matter. So that was the purpose of this slide. All right. Next, I have is types of depression. Generally speaking, we can divide depression into broad categories, and that is, number one is endogenous depression. Endogenous means within the body. So biological based depression, you can say. There's no outside stressful event that you can think of. And then the second one is, of course, the opposite, outside, exogenous depression. So we call that reactive depression. What do I mean by that? So let's say that you have a client, um, let's say 45-year-old male who lost his job. He was fired, he was let go, and now he's he couldn't pay his mortgage or rent. He lost his house or apartment. His spouse left him. He has no family, no social support, no financial income, and he's homeless now. And because he's homeless, he is depressed. Okay, now that client will fall under reactive type of depression, exogenous, outside. There were some stressful or traumatic event that took place that lead up to depression. So it's very important to really ask the client, tell me what happened, right? Now, but versus this, the opposite example would be, the second example would be, same patient, let's say 45-year-old male, who all of a sudden started feeling depressed, depressed up to the point that not able to do ADLs, did not show up to school or work, and was let go, lost his job because of depression, and therefore lost his house or family, and now he's homeless and has depression. So depression came first. Depression came within, so that would be endogenous depression. So that would be a biological. Needless to say, for here, the main reason was the financial, right? So if we can find out, whatever vocational training that a person has, whatever occupation they did, if we can find them the job and then support them financially, then the chances are depression will be gone, because that was never the main concern here, right? So this is a different type of issue that can be treated with money, if you will. But money not necessarily going to help this client, because their issue was never the money. Their primary issue was depression. So we have to treat the underlying depression first before they can apply for a job and move on into the society, back into the community, I should say. So what is etiology of depression? Depression is such an overwhelming, devastating experience that it really demands an explanation, like what happened, what's going on, and we may never be able to find the answer why all of a sudden somebody get depressed. But there's several theories, all right. I would say it's a multifactorial, and the first one is psychological factors. People believe in a cognitive theory where the underlying assumption for this is that the way you think, it matters. So if you think positively, you're going to have positive outcomes, and if you think negative, you're going to have a negative outcomes. So positive emotions, and look at your life from a positive standpoint of view, and that's usually the assumption for a few psychotherapy interventions that you will learn later on. But the main point here is that some people, they develop maladaptive techniques to deal with their stress. We all have stressors, right? So some people develop a maladaptive technique, and with the help of psychotherapy, the point is to identify those maladaptive behaviors and replace them with coping skills, healthy coping skills. For example, if you have a client who has issues at work, let's say with a manager, supervisor, or whatever, and a maladaptive response to those stressors at work would be that client is now drinking alcohol, right? So you have to identify that that's maladaptive, that's not healthy, and replace that with coping skills such as, oh, let's arrange a meeting with the supervisor. Can we sit down and talk about it, and then offer options? If nothing works, then leave. Give them 2 weeks notice, whatever. Instead of being dependent on alcohol or something like that, right? So that was just one example. So anyways, that's one theory. And then there is a theory of biological factors. So genetics. I think we know this very well, that many disorders tends to run in the family. So there's a clear evidence. Multiple studies are done. Twin studies consistently show that genetic plays an important role in depression and many other mental illnesses, of course. In some cases, we may have imbalance or dysregulation of hormones, so that can play a role in some patients. And we saw that during postpartum depression. Remember, we talked about that. And my favorite, biochemical. We believe there's a deficiency of some neurotransmitters, and two important neurotransmitters that we believe play a role in depression are serotonin and norepinephrine. So please understand that we believe that low level of serotonin and norepinephrine can cause depression. Now, and I know that I'm making it so simple when I say that, oh, it's a low level. In reality, it's more complex than this. We believe it's not necessary there's a deficiency of one. We believe that there's imbalance, so it's like to have a perfect recipe to prepare a meal or dish, and how much salt do you need, how many black peppers, red pepper, whatever you need, different spices to create that dish. And then if there's imbalance, then the dish is not going to come out the way you wanted. So it's that kind of concept. So think of it's more complicated than just saying that it's a decrease, but to simplify and to understand drugs, it's okay to call it that it's a decreased level of, or low level of, a deficiency of two neurotransmitters, serotonin and norepinephrine, and our entire pharmacology will revolve around these two concepts. All right. So what I'm going to do now is I'm going to just introduce DSM criteria for major depressive disorder. Now, I'm not going to go in detail with this because you do have access to this. So this is something that you can always take a look at it. Please understand that there are different types of depression, and DSM criteria will change depending on what exactly you're trying to treat or diagnose, I should say. But generally speaking, please understand that the common feature for all of these depressive disorders are going to be pretty much the same in the beginning, such as the client is going to report that I feel sad, or I'm empty, or mood is going to be irritable. They may not be able to sleep, or they're sleeping too much perhaps. So you're going to see that depressive mood. Now what will change on the DSM criteria is in order to come up with other differentials based on the fact that for how long these symptoms have been going on. For example, 3 months, 6 months versus years. So that would be persistent depressive versus major depression. Is this the first episode? Was this treated in the past and now came back? Is it recurrent depression? So what is the timing duration, and so forth. So anyways, so let's take a look at the major depression disorder. According to the DSM criteria, you have to have a 5 or more of the following symptoms. And remember, since this is a major depression, the symptoms must be present during the same 2-week period and represent a change from the previous functioning. So there has to be a significant change from the baseline mood, if you will, right? And at least one of those symptoms should be either number 1, which is depressed mood, or number 2, loss of interest or pleasure. So what they're saying is that you have to have a 5 or more, but one of those 5 or more must be either number 1 or number 2. You cannot have number 3, 4, 5, 6 and all that and then call that those 5 items meeting the criteria for depression 1 if 1 and 2 are not a part of it. So 1 or 2, sometimes both of them are present, but 1 or 2 have to be present in order to call major depression or major depressive disorder. So what is number 1? The client feels depressed almost most of the days, nearly every day. Okay. Now in children, be careful, because sometimes the way they explain their mood is a little bit different. So the mom or parent or grandma or even a patient will tell you that I feel irritable. So in children, adolescent, irritable mood is also considered as number 1. So it can meet that criteria. And number 2 is your loss of interest or pleasure. And remember, it has to be something that they used to enjoy. It cannot be something, for example, if you ask, do you like going out with your friends, and then the patient say no, you cannot say, well, the patient is meeting number 2. At one point, somebody has to report that I used to enjoy doing that. So if I never enjoyed swimming and I do not enjoy now, that's not depression. But if I tell you I used to enjoy cooking or dancing or swimming or going out with my cousins or friends, and now I don't, so that is a loss of interest. So remember, there has to be significant change from the previous behavior or previous function. And number 3 is either significant weight loss or weight gain. We know that some people, when they're depressed, they lose their appetite, they don't want to eat, and some people they want to eat more when they're depressed, so they gain weight. It should not be intentional, so not intentional weight loss or weight gain. All right, so number 4 would be insomnia or hypersomnia. So remember, just like appetite, I told you that some people can have a loss of appetite, and some people actually like to eat more during depression. Same thing, some people like to sleep a lot, they feel sleepy all day, and some people will report that they cannot sleep. And some clients may have a psychomotor agitation, they feel restless. Fatigue is a very, very common. As a matter of fact, one of the main reasons they come to the clinic is fatigue, and we always want to rule out physical causes. So we check their CBC and TSH, make sure it's not a hypothyroidism, and that will be part of the diagnostic criteria as well. I'll show you in a second. And a feeling of worthlessness or inappropriate guilt they may have. Diminished ability to think or concentrate, and so forth, and thoughts of death. So you may have a client with a suicidal ideation, and so make sure you ask them, do you have a plan? And we'll talk about that in a second. Okay, so that was A criteria A. Now the B criteria is that these symptoms cause clinical significant distress or impairment in social, occupational, or other important areas of functioning. In other words, there has to be some impact on their ADLs or functional ADLs. Just remember one thing moving forward. Anytime we diagnose a client, we have to ask a question. So what? Like, what exactly is the impact of that disease? What is the burden? Where is the deficit? Why am I giving you a diagnosis? What's the point of diagnosis if it's not going to change the course of the treatment? Are you going to prescribe something? If the answer is no, then there's no fun of diagnosing someone. So the easy example would be maybe like OCD, or we always joke about that oh my gosh, I have OCD, or some degree of anxiety. But if it has no impact on someone's life, and even let's say somebody likes to drink glass of wine every single night, during dinner, but I would not call that client issues with alcohol, or because if the patient or the client is able to get up in the morning, take a shower, go to work, and is very productive, then where's the deficit? As long as their liver function is okay and there's no impairment from physical and mental standpoint of view, then what's the point? So you will see that DSM talks about this a lot. For every single thing, you have to say, okay, do I have a significant distress? And sometimes it's more than one setting, like school, work, social gathering, and so forth. Okay, and then this is also a very, very common criteria. You will start seeing the trend throughout the DSM that they will say that number one, make sure there's a issue, some kind of impact on the ADLs, and make sure it's not caused by physical health. Like you have to make sure this is truly a psych issue and not a physical medicine issue. In other words, the patient can't sleep, the patient is tired and all that. Is it because of pain? Is it because of hypothyroidism, anemia, cancer? So we have to rule those things out because the treatment is different, as you know. Anyways, take a look at it. I think you got the point here. So the option D here is that these symptoms are not better explained by any other mental health disorders. So the first one here was these symptoms are not explained by physical diagnosis, and here these symptoms are not explained by some other mental. For example, is this a substance use issue? Is this bipolar? Is this schizophrenia? Is this ADHD, and so forth, right? Is it insomnia? Is this anxiety? So you have to give them a correct diagnosis. For major depression, there has never been a manic episode or hypomanic episodes. Now this is very, very important. What happened is, remember earlier I was telling you that if symptoms are always on this side of the pendulum, and I call that a depression side, right? This one, and here was mania on this side. Now what happened is, you can have a client who is always in a unipolar on this side, right? A true depression case, right? Which is far more common than bipolar, of course. Depression is more common than bipolar. But let's say that every single time you saw a patient, you always saw this patient on depression side. You have no reason to call this as a bipolar, because those episodes were never ever reported to you. All you know is that your patient has depression, but you ask these symptoms about the manic episodes. I'm going to talk about that in a few minutes. But if there's an evidence, if somebody told you, either patient or their significant other or a family member, anything about a mania, then if somebody told you about a mania, even if today a patient is in depressed mood, we should not call that depression. Okay, that would be a bipolar disorder, and that's so important to understand, because then treatment will be different for bipolar than depression. Okay, so that's what this is telling you. Okay. All right. So we do have some screening tools that we can use. Remember, this is not really like a diagnostic tool. These are screening tools. So some facilities use Beck Depression Scale, Montgomery. There's so many. The one that I have in front of you is a PHQ-9. It's a patient health questionnaire. It's called 9 simply because there are 9 items. I know the font is small, but if you take a look at number 1, it says a little interest or pleasure in doing things, and number 2 is feeling down and depressed or hopeless. And I don't know if you remember, but recall from the DSM criteria, remember it says that you have to have those at least 5 of those symptoms for the past 2 weeks, and out of those 5, you have to have at least one of the first 2 items on the list, and then those 2 items were either depressed mood or loss of interest. That's where these 2 questions really come from the DSM. And then what they're saying is the same thing over the last 2 weeks. So pretty much this really helps you to align your symptoms with the DSM. Now they're saying that if you do not have the top 2, you can really stop at that point, because then you're not meeting the criteria for depression. Remember, you have to have one of those 2. So it's either not at all, or more than half day, or nearly every day. But if the patient tells you that these 2 are not at all, then sometimes what people do is they can say PHQ 2 equals 0. That means you did screen the patient and it's not meeting the criteria. But if the first 2 are either several day, or at least 1 or maybe 2, something like that, then you have to open up the entire PHQ-9 and then do the calculation, add those numbers up. Now when we add these numbers, any number more than 20, I should say, is your major depression. So major depression disorder is more than 20, and if it's 5 to 9 or less than 5, you can say 5 to 9. That's less than 5 is, I will just keep an eye on them. 5 to 9 would be minimum depression. So you can do education, maybe psychotherapy. You can, if it's a 10 to 14, then that would be minor depression. 15 to 19 would be major depression, and then of course I told you more than 20 would be a major depressive disorder. Now this does not mean, pay attention to this because this is important, this doesn't mean that the client has a score of, let's say, 7, and you can say, oh, it's minor, just go home, we can do talk therapy. No, remember, these are just numbers. If the number is small, these are not like a mathematical equations. You can say, well, 7 is smaller than 20, and then you're not that bad. These are symptoms. Just because the number is adding up into the minor depression, their symptoms, they may not feel that their symptoms are small or minor. Those symptoms may be very overwhelming. Remember, just like we ask a patient to describe their pain at 0 to 10, right? So just because somebody said 6, you cannot say, well, it's not that bad. Your roommate has 9 out of 10. Well, their 6 is bad. That's all they care about. So be very, very careful with these. So my point here is, even if the number is small, sit down with them and offer antidepressant medication if that's what they're interested in. Give them help. And the opposite is also true. Just because the number is, let's say, I don't know, 16, that doesn't mean that they have to have antidepressant right now. If they are telling you, no, I would rather go through psychotherapy, I would rather talk to my friends and family, have a good social support system, and that's okay. Yeah, you appreciate that, but offer them the treatment, and let the patient decide what they want to do. So I think the point here is, this is a conversation that needs to happen with our patient, instead of we dictating what they need to know, what they need to take. So when you have a client who's depressed, it is very, very important to assess for suicidal ideations or homicidal ideation. It's okay to ask directly, do you have thoughts of harming self? Do you have any suicidal ideations, or do you have any thoughts of harming someone else? Do not, please, do not hesitate to ask. I know it's a very sensitive question, but you have to ask. It's a direct question, and you need to document that as well. Um, but be sensitive, be careful when you ask, though, of course. The timing has to be right. So talk to your patient, make sure you have that good relationship with the patient. But as you know that, when the client feel that they have a lot on their plate, their suicidal ideation is really a manifestation of their inner pain. They are suffering, they feel hopelessness, right? There's no they have a lot on their plate, and they feel that this is the only way out. And we sometimes patient may make overstatement that I can't take it anymore, I wish I was dead, everyone would be better off if I died. These are overstatements. Sometimes patient may make cover statement, for example, everything will be okay soon. So when somebody make their statement, don't say, oh, I'm glad to hear that, these are the red flags. You say, tell me more about what do you mean by that. One thing you have to be very, very careful is the way we talk to our patients. So you have to use that therapeutic communication skills. Tell me more. Ask them open-ended question. Never ask closed-ended questions. Don't tell them, you don't have any pain, do you? Those are closed-ended questions, right? Tell me what is bothering you. What is, how can I help you today? Never ask why questions. Why did you do it? That's a non-therapeutic. So tell me more. Explain that. Those type of deal. Okay. Okay. So let's talk about treatment now. So let's say you have officially diagnosed somebody with a depression. You did all the workup. Remember CBC, the TSH, the whole 9 yards, right? And the patient is meeting the criteria for DSM. What is your next step now? How do you treat? As we know, anything in medicine, first step is usually, I shouldn't say almost always, but most of the time it's a non-pharmacological interventions. So we start off with a psychotherapy, so talk therapy. You will learn that later on, but it's a verbal therapeutic communication skills technique that helps the clients to overcome depression, learn some coping skills, and so forth. One of the examples, very common example, is a CBT, cognitive behavioral therapy, and they focus on to identify and correct those maladaptive pattern, if you will. Um, Another non-pharmacological intervention is the one that you are looking at right now is ECT, electroconvulsive therapy. Now, I am not saying that this is your go-to treatment. This is listed first simply because we are talking about non-pharmacological, but this treatment is invasive, and therefore it is actually reserved after a pharmacological intervention. So please understand that part. There are so many studies done on this treatment, and in my opinion, ECT is very superior. It's far superior than any other treatment that we have, to be honest with you, any of the antidepressant medications. But the reason we don't use this as a first line, because it's invasive, and it can cause some serious side effects. So one thing I want you to think about when you are going to refer a patient for ECT, let's say, is make sure you have tried that patient on multiple antidepressant medications and some other therapy as well. and then it's a resistant depression. It's you tried maybe 2 or 3 in different class of drugs, and patient is not getting better, and patient has either suicide ideation or maybe failed attempts, and then you want to refer this patient for ECT. And the old ECT technique that we have seen in Hollywood movies or Bollywood movies has very bad reputation. Just understand that that's very dramatic. That's not how we do it. The new technique is very, very safe. It's not as dramatic as you see on the televisions and the movies. So anyways, ECT is carried out under anesthesia. So we do give medication, for anesthesia, and there's no actual seizure movement that occur, because what we do is we only give we pass the electricity to see the effect on the brain and not the entire tonic-clonic activity. So the current will pass for maybe 1 to 2 seconds or so, and it will cause grand mal seizure, but the activity of the seizure will last for 1 to 2 minutes. So the current will pass 1 to 2 seconds, and then the seizure will last for 1 to 2 minutes, if you will. If the seizure is lasting more than that, then of course they stop the ECT, and then they'll give like Ativan, IV Ativan, and benzodiazepine and so forth. The ECT procedure itself is not painful. It's painless. A client may report headache, next day or so, but very safe, to be honest with you. So patient will be NPO night before. Just think of like taking client for like outpatient surgery. It's like think of like a surgical procedure, NPO night before, and so forth, right? So sometimes client may feel very good after one treatment. Sometimes patient may need more than one treatment, and as I mentioned before, that it's really reserved for people who are severely depressed. Work very well, very, very good outcome from this procedure. Another patient teaching would be that the ECT may cause some memory loss. So that's one thing that we need to tell the patient. And if a client has a severe like osteoporosis or maybe severe respiratory cardiac issues, then those clients are usually not a good candidate, I should say. If you can only imagine if you have a client with osteoporosis, especially severe osteoporosis, and you're giving causing seizures, giving electricity, they can have fractures and so forth. So those would be good patient teaching, if you will. Okay, so the next treatment, again, non-pharmacological interventions, is light therapy. This type of therapy is good for a seasonal affective disorder. So you see this type of depression in countries or in areas where especially during the winter month, when the daylight time during the winter is very, very limited. So people usually get benefit from these type of treatments. Then you also have brain stimulation or a magnetic therapy. So similar approach to ECT, if you will, but the benefit here is number one, as you can say clearly, this is outpatient, so patient is not going to be in the OR, in the hospital, and it's less invasive. You're not causing seizures through electricity. This is a magnetic approach, and it does have decent result. Some people they brag about it. Some patients they feel better after a few treatments. I do know a few patients who had very minimum result, or they were not satisfied, I should say, from the outcome. But that option is there, and I'm also aware that they're actually working on this treatment, trying to really advance this technology. So this might be the future. So we'll see what happens. They're trying to really calculate the exact amount, especially in the acute care settings. The client comes in with the depression, how much we can give, and how often can we do 3 times a day, and then for 3 days or so, and then really treat that depression and discharge this patient back home from the hospital. Wouldn't that be neat in the future? But right now, you do need a multiple settings, if you will. Okay, so the concept is the same. It's a powerful magnet that is placed on the skull, and the principle is to stimulate the brain regions. And the next one, non-pharmacological interventions, believe it or not, is exercise. There are many studies that are done that when we exercise, we actually increase our serotonin levels, and that's what is low in depression, right? Just like exercise will help with a diabetic patient, with insulin, right? When there's a resistant to it, especially in type 2 diabetes. Same concept. I always tell my patient, do you want me to prescribe something that is 100% covered by insurance? There's no copay, and they get very excited. Yeah, do that. So I grab my prescription pad and I go, exercise, 3 to 5 times a week. And the point here is it's very beneficial. All right. So next stop for non-pharmacological interventions for depression is herbal treatment. So you have St. John's wort in front of you. Look at this lovely flower here. This is not something that we are prescribing. This is something that a patient has already talked to someone else, maybe either online or friend recommended or family, and they're already taking this. Our job is to ask them, are you taking any over-the-counter supplements, herbs, anything that I need to know, because we know that St. John's wort actually work very well. By the way, this is a good herb. It works by increasing the amount of serotonin, norepinephrine, and dopamine, all three major monoamine neurotransmitters that are considered low in depression. This guy will increase it, so it works very well. But the problem is, if you don't know that the patient is taking it and you're also prescribing a medication, let's say SSRI, you're also increasing serotonin, we can have a big problem. Okay, so in order to avoid that, ask those questions. If the patient is taking it, I usually do not tell my patient not to take it, because it's their body. My job is to let them know few things. Number one, it is not FDA approved. We don't know the exact concentration, exact amount, and it's up to them if they want to take it. And if they're taking it, maybe I should either not start them on antidepressant medication if I have to. If their symptoms are not managed, maybe start at a low dose and monitor them very carefully, bring them back, follow up, be very careful. So let them know that it's not a regulator, so be very careful here. Okay, so there are some drug interaction. It doesn't get along with the digoxin and warfarin and dilantin and so forth. So if the patient has depression, let's say, and on top of that taking some pain medications, or maybe patient has a CHF and depression on top of that, and patient is either on digoxin or so forth. So these are, this is a patient teaching, and then we should intervene at that time. All right, so now let's talk about pharmacological interventions for depression. There are maybe like 5 common classification. At least I organize them in 5 categories. And the first one on the list is your TCAs, tricyclic and related antidepressant, for example amitriptyline in front of you. Now I'm not saying that this is the first line treatment, I just organize them in 5 different categories. The second option here is a selective serotonin reuptake inhibitor, or SSRIs. Then I have SNRIs, serotonin norepinephrine reuptake inhibitors. And then we'll talk about monoamine oxidase inhibitors, MOIs. And then at the last we'll talk more about miscellaneous drugs, and this is where we'll talk more about Wellbutrin maybe, and Remeron, and Trazodone, and ketamine, and so forth. Okay, so why don't we have discussion of these drugs one at a time in depth. All right. So the first one on the list is a tricyclic and a related antidepressant, TCAs. So the examples are amitriptyline and nortriptyline and so forth. So the way the TCAs work, the mechanism of action is that it will prevent the reuptake of both serotonin and norepinephrine. So what happened here is, so this is your presynaptic neuron, and it has vesicles. We know that. We talked about this concept. So presynaptic neuron has multiple vesicles that has different neurotransmitters in them. So let's say that this one has a serotonin today, and this is your post-synaptic neuron. So the pre wants to talk to the post with the help of neurotransmitters, let's say serotonin. These neurotransmitters will be released into the space between pre and post is called synaptic cleft. We also know that post-synaptic neuron has a specific receptors attached to them. Remember, dopamine will have its own receptors, like a dopamine 1, 2, 3, and acetylcholine different, and GABA and all that, right? So once the neurotransmitters is attached, the message is shared, conveyed, and then after that the activity is over. Then 2 things will happen. Number 1, it will be destroyed by the enzyme, so degradation by the enzyme, and then the leftover residual neurotransmitter will go back, and we call that reuptake, right? So that reuptake is stopped by TCA. Reuptake of both serotonin and norepinephrine is stopped. So when you stop the reuptake, that means you're not going to allow these neurotransmitters to go back. That means you're going to have increased concentration of these neurotransmitters in synaptic cleft. And sometimes that's all you need to change the mood, to make these patients feel better. Now you have an increased concentration of neurotransmitters, and that was the problem, right? They had a low level of serotonin and norepinephrine, so we just gave them a little bit more. It's going to stay there for longer duration. That's what happens here. Now they work very well, by the way. It seems like they should. You're increasing their serotonin and norepinephrine, and they do work. The problem is, the reason they are not our first line treatment, because they're increasing both of them, both serotonin and norepinephrine, they're causing a lot of side effects. So sometimes they're considered like a dirty drugs, if you will. 2 main side effects you want to remember is, the number 1 would be, you can say, anticholinergic type of side effect. So what is that, anticholinergic? Well, that would be your dry eyes, dry mouth, constipation, urinary retention. So those type of side effects, right? Now the second would be your antihistamine type of side effect. So antihistamine. So think of like sedation. When you think of antihistamine, I think of like a Benadryl, right? So think about that. So sedation, you feel dizzy, you know, so patient can have a fall. That's never a good thing. With anticholinergic, you can have a weight gain. So you can see that, especially if you have a client who's depressed, you're giving these antidepressant medication that can have a significant side profile history. So that's not a good thing. You don't want to treat depression with a medication that can cause a fall and hip fracture. That's not a good thing. Okay, so needless to say, they're not your first line, but they do work very well, though. Keep that in mind. All right, so now next classification is one of the most important drug classification in the management of depression or even anxiety is SSRIs, selective serotonin reuptake inhibitors. And the examples are a generic name sertraline, or a brand name is Zoloft. Prozac is afloxetine, and Paxil, Proxetine, and fluoxamine. Celexa is citalopram or Lexapro. The generic is escitalopram. All right, so let's talk about the mechanism of action of these drugs. Well, it's going to be very similar to our TCAs. The main difference is going to be that, remember with the TCAs, we had a reuptake of pretty much everything, norepinephrine, epinephrine, the serotonin and so forth. Now here we are selective to serotonin only. So when you have a presynaptic neuron, here comes the serotonin, and we will prevent the reuptake. And that means if you're going to prevent reuptake, you're going to have increased concentration of a serotonin in the synaptic cleft, and sometimes that's all you need. Now, it's not 100% selective, so you may see some reuptake inhibitor on norepinephrine, but the effect on norepinephrine is small enough that it doesn't really give us the side effect, the one that we saw with the TCAs. So this classification is a much cleaner. We call them cleaner, neater drugs. In other words, the patient tolerate these medications very well, so well that this drug classification has changed the way we manage depression nowadays. This has become the first line treatment. Almost always we start our patients on SSRIs, and patients tolerate them very well. Now, some patients may report some side effect, and that's going to be like a GI side effect, nausea, vomiting, maybe mild loose stool or diarrhea, or maybe some degree of a weight gain. Now, weight gain can be beneficial in some settings. You may have a client with a depression who has a very poor appetite, so that might be a good thing to increase appetite or weight gain. Another very annoying side effect can be decreased sexual urge, or sometimes even hyperstimulation, like a tremors and so forth. Fluoxetine can do that. I have had patients who are on fluoxetine and some side effect of tremors. It's a discussion with the patient. Do we need to continue fluoxetine or any drug for that matter, or do we need to change that drug with a different agent within the same classification? For example, let's say a patient is on a fluoxetine or Prozac, and you're dealing with the tremors. We can give something else, like perhaps, let's say, Paxil, and that's fine. But sometimes if the medication is working very well, like they're happy with the therapeutic effect, then sometimes we can add another agent like a beta blocker, low dose of propranolol, to manage the tremors, especially if we found a good medication, a good strength, and patient is overall reporting decrease the symptoms of depression. So why change? But sometimes we might have to change, by the way, and that's okay. One drug within these 7 different types of SSRIs, one is not necessarily superior than the other. We really need to find the one that works for our patients. All right, so and a few things that I want to tell you about these drugs. Number one is black box warning. All SSRI carry the black box warning of increased suicidal ideation, especially in children, adolescent population, and young adults who have a history of depression or some other psychiatric conditions. Now, remember, these medications do not work instantly. It takes several weeks for these medications to kick in, so that's a very good patient teaching. Sometimes it may take about 4 to 6 weeks or so for these medications to kick in. Unfortunately, you are going to see the side effects first before you see the therapeutic effect. So that's a good patient teaching. Patient may stop taking the medication stating that, oh gosh, it's day number 5, I don't see any difference. As a matter of fact, I feel nauseated, I don't need this medication. So it's a good patient teaching that, hey, these side effects are transient, they will go away, and the therapeutic effect will kick in. Please keep taking it. As long as you don't see any true allergic reaction or anaphylactic, then keep taking it, and then you will see the therapeutic effect. Okay, another teaching point is that this medication, because it takes several weeks to kick in, that means that this medication needs to be in the system for a while, right? So this medication cannot be taken as needed. This is not a PRN medication. So that's important concept. Another important thing about SSRI is that once you start a patient on one of these SSRIs, let's say Zoloft, let's say you started somebody on 25 milligram of Zoloft, and then after several weeks they were tolerating quite well, no side effects, and then maybe you increased it to 50, and maybe several months later now you're sitting at 75, and the patient is overall doing much better. Do not get excited and discontinue the medication when the patient feels much better. Keep them on the same dose, maybe if the dose is not too high. Keep them on the same dose for several months. Sometimes I keep them for 1 year, at least for 9 months or so, and then do a very good evaluation, and then start tapering them off if that's a decision you made by having discussion with the patient and the family maybe, and very slowly we taper them off, something that I call GDR, gradual dose reduction. So from 75 to maybe 50, and keep them on 50 for a while, and then maybe 25 and so forth. The reason behind that is that if you discontinue the medication early on, maybe you just were able to manage their symptoms superficially, but did not treat the depression. And then if you discontinue early, and when the symptoms come back, and they might be resistant to these medications, you might have to start on a higher dose, and it's very difficult to treat a second episode or a third episode. So once you find a good drug and good strength, and the patient is tolerating, keep them, please, and document all that and give them a good information. Now, so we talked about depression. Now, same is true with anxiety. Remember, SSRIs are pretty much the first line treatment, gold standard treatment to treat anxiety. And then the reason behind that is, well, now we know that amygdala, that's where the anxiety lives. Amygdala becomes less reactive to to perceived threat when serotonin is available. So when we increase the concentration of a serotonin, you can calm down your amygdala, so you manage your anxiety. All right, now let's see if I need to give you more information on something. Okay, yes, so Celexa. So let me talk to you about the difference between citalopram and escitalopram. Actually, before I do that, let me go back and make my point when I was talking about black box warning and the suicidal ideation. What happened is we have to be very careful when we give SSRIs or antidepressant, any type of antidepressant, to any population for that matter. Remember earlier I said it takes several weeks for the medication to kick in, 4 to 6 weeks, and maybe sometimes 2 months. Now, in the beginning of the treatment, we have to be very, very careful, because what can happen is let's say that you had a client who was suffering from a major depressive disorder with suicidal ideation, and they were so tired, very fatigued, they had no energy to do anything, but they had a plan to harm themselves. We gave them SSRI. That means we increased their serotonin level just enough that we gave them some energy, but not enough that we have treated their depression yet. So the amount of energy they get from the first few weeks or so sometimes is a good enough that the plan that they had before they started on SSRI, now they have energy to carry out that plan. So we have to be very careful and monitor them very frequently in the beginning, and that's a good patient and family teaching, that hey, keep an eye on your loved ones when they start having a lot of energy in the beginning. You need to increase visitation, and then keep an eye on them, and then hopefully once the medication fully kick in and then the therapeutic effect kicks in, they'll feel much better. So that's why I hesitate to give a lot of refills, especially in the beginning. We want them to come back to the office and follow up with us, and we can go over the side effect, make sure they're tolerating very well. Do we need to increase the dosage? And then especially ask them about suicidal ideation. That assessment should continue throughout the treatment plan. Okay, another point I wanted to make was the difference between Prozac and Paxil. Most SSRIs are considered activating. What do I mean by that? Well, when the drug is activating, that means it's gonna help to increase your energy. It's gonna increase your mood, or when you have a client who's depressed and the client is very low in energy, and when you take a Prozac, you feel better. Some patients have actually reported that they feel better within the first dose or so, right? They feel very energetic. So that's a good thing. Now the problem with the Prozac is that it's not a problem, but the concept is, because it is very activating, we have to be careful, and I usually do not prescribe this medication for the client who's very agitated, or the client who has insomnia, because if you have a client with insomnia, and especially if you take this medication in the evening or afternoon or at nighttime, it's going to keep them up all night long, because the medication is very activating. So that's not a good drug. Now, Prozac is also approved for bulimia and OCD, so that's just a side note. Now, Paxil, on the other hand, is very calming. It's the opposite of Prozac. So Paxil is very sedating, you can say, unlike Prozac or Zoloft. Zoloft is also activating. Now, what happened is, because Paxil, it's very calming, so I give them at nighttime, so that helps with the depression, with the mood, and helps with insomnia, if that is the issue. Um, it does carry some like a mild anticholinergic properties, and perhaps that's where the sedation or the calming effect comes in. All right. Paxil is also approved for generalized anxiety disorder, so that makes sense. It's a calming drug. It's also approved for OCD and PTSD as well. Now, some people also use Paxil to treat hot flashes. Remember, it will increase the serotonergic activity. So women who suffer from hot flashes are a good candidate for this drug. All right, now I want to talk about citalopram and escitalopram. Now, what happened is citalopram is a racemic mixture made up of two forms, if you will. I'm going to put C here for citalopram, and it's going to have two arms, R and S. Now, R and S are these are the mirror image, like isomers. I'm pretty sure you know what isomers are. These are the enantiomers in a way that they share the same chemical formulas, but they're oriented differently in space, as if they are standing in front of a mirror, if you will, right? It's a mirror image, right? So the chemical formula is the same, but the arrangement is different. So what happened is the R enantiomers is associated with QTC prolongation. So that's not a good thing, right? So R can cause a QTC prolongation. So in other words, Celexa or citalopram, one of the side effects of that is QTC prolongation, not a good thing. Now, we what we did, we cleaned up the formula by getting rid of R altogether. So we cross this off. I'm going to change the ink real quick. So we crossed this off, and we came up with pure form of S enantiomer. And because S had nothing to do with the QTC prolongation, so Lexapro or escitalopram is a cleaner drug or safer drug. As a matter of fact, that is my go-to drug for depression, especially in a geriatric population, because most of the geriatric clients that I see, they do have underlying cardiac history. So I don't want to give them a citalopram. But in either way, I do keep an eye on the EKG. I do check just to be in the safe side. But in my opinion, Lexapro or escitalopram is one of the best tolerated SSRI with very minimum drug-drug interaction. So I prescribe that a lot. All right, now let's talk about SNRIs, the serotonin norepinephrine reuptake inhibitors. We have three examples. We'll start with venlafaxine, which is Effexor. Now, it's some people believe that SNRIs are superior or they have a greater efficacy in treating major depression disorder than SSRIs, but we still, just so you know, we still start people with SSRIs because that is the first line treatment. People tolerate that medication very well, but SNRIs are also very, very good options. Now, venlafaxine is also approved for generalized anxiety disorder along with the depression, of course, and I do prescribe this drug a lot. The good thing about this drug is that actually it comes as an extended release. So instead of a IR that was giving side effect like nausea and so forth, so we use XR I start patients on like a 37.5 milligram, and then increase to 75 and 150. 225 milligram is the max. One thing to keep in mind that when you have a patient on SNRIs, we really want to taper them off very slowly, because you can have withdrawal side effect, especially if you're treating anxiety. Now, the issue with venlafaxine is that the efficacy is unpredictable. So we have a drug called desvenlafaxine or Prestige. Now, this medication is really an active metabolite, so you solve that problem of efficacy here. It's off-label. Well, of course, it's for depression, but off-label use is premenopausal women with hot flashes and night sweats and insomnia and depression. It also comes as an ER, like a 25 milligram or 50 or 100 milligram per day. Next is a duloxetine or Cymbalta. That's very interesting drug. Of course, it helps with the depression, but along with the depression, if the patient has a comorbidity of a pain with the depression, that this might be a good medication. There was a time when we didn't have a better understanding of depression. We didn't know that depression can be painful. How like a broken bone, we know it's a painful. If you have a knee injury or if you have chest pain, we understand it's a painful, so we give pain medication. That concept was not clear in the setting of depression. When people used to say I'm depressed, we'll say, oh, I'm sorry to hear that. Or if I'm in pain because of depression, we didn't think that it's a pain like ouch type of pain, right? But now we know that you can have a severe body pain when you are depressed. So if that is the issue, then perhaps we can consider duloxetine. Now, interesting thing about duloxetine is that it's a good medication if you have just depression without any other comorbidity. So depression alone without any pain, or if you have a depression with pain, we can consider this medication, right? Or maybe you have just pain without any depression, right? Or pain with depression, if the pain is the primary, like osteoarthritis type of pain, musculoskeletal fibromyalgia type of pain with depression. So in other words, all different types of depressions or all different types of pains can be treated with duloxetine. I usually start with like a 30 milligram BID and maybe take it to 60 milligram. 120 milligram per day is the max. The idea here is to really use different tools and sometimes use these medication as a monotherapy and perhaps adjunct therapy. Okay, now let's cover a very important and serious complication called serotonin syndrome. What happened is any drug, either psychotropic medications or maybe non-psychotropic medication, any drug that can increase the level of serotonin can cause serotonin syndrome. So for example, we have antidepressant medications such as SSRIs, SNRIs, and TCAs and MOIs and so forth. They increase serotonin level. On top of that, some non-psychotropic medications such as your nausea medication like a Zofran, your pain medication Tramadol and triptans and so forth, fentanyl maybe, they also increase serotonin, and even some herbs. Remember St. John's wort, that this will increase serotonin levels. So can you imagine you have a patient who was on, maybe patient was depressed and it was painful as well, and maybe PCP started this patient on Tramadol, and the patient was also taking herb and came to you, and then you started this patient on maybe Zoloft or any other SSRIs, and now you have 3 agents that are going to increase serotonin. So this patient might be at a higher risk of serotonin syndrome. So that's why it's so important to collect all the history and have them bring all the medications, including over-the-counter and herbs that they're taking. Now, the presentation for serotonin, it's very, very important from a clinical standpoint of view, and of course from the academia and exam standpoint of view. You really need to know this concept. So I want you to think of a phevom when you think of serotonin, not a fever, but a phevom with M at the end. I'll tell you why. So F stands for fever. So all of a sudden you have a sudden, elevated temperature. E stands for encephalopathy, so sudden mental status change. So the patient is disoriented all of a sudden. This is not your typical like a dementia, Alzheimer type of disorientation. This is a sudden acute change. V is for vital signs are unstable, so high blood pressure, tachycardia, diaphoresis. So they're sweating a lot. Enzymes are going to be elevated, and more specifically CPK enzyme. And then M stands for a motor hyperreflexia. In other words, hypertonia, or like a tremors, clonus, may have a seizure activities as well. So the first thing we should do is, of course, we discontinue the medications and keep an eye on them and provide supportive care. All right, so the treatment, this patient will be admitted to the acute hospital, of course, and cyproheptadine will be given. The mechanism of action is that it is serotonin receptor antagonist, so it will decrease the level of serotonin, and so like a reversal agent, if you will. And we might have to restart the patient on a lower dosage. Well, first of all, identify if they were taking any other medication than SSRI, and start maybe on either different medication or at a lower dose, and good patient teaching after that, of course. Now, if left untreated, you can have a severe rhabdomyolysis, kidney failure, and even death. So it's very, very important to educate our patients and watch for polypharmacy that can raise serotonin level too high. All right, so number 3 is monoamine oxidase inhibitors, MAOIs. Remember, serotonin and norepinephrine and even dopamine, they all come from the same category, monoamine. These are monoamine neurotransmitters. So the enzyme that will destroy serotonin and norepinephrine is called monoamine oxidase. So remember, here in the synaptic cleft, these enzymes will destroy them, degradation, right? So if we can inhibit that enzyme altogether with these medications, if you inhibit the enzyme, that means you will increase the concentration of norepinephrine and serotonin or even dopamine here for the longer duration, and that will help our patient, right? Because their neurotransmitters were low. So that's how it works. This medication is very powerful, work very well, but just like TCAs, it's not a good, it's not a first-line treatment because it does have a lot of side effects. So you will never ever prescribe this as a first line. This is always adjunct to treatment later on for someone who's not getting better. My advice is always start with SSRIs, and then you really want to either keep increasing the dosage of SSRI, and then maybe try a different drug from a different class before you really think of MAOIs.
Okay, so the two things that you need to remember is that number one, it does have a anticholinergic side effects and so forth, but the main thing is the interaction with the drugs and with the food. So it does not get along with most of the narcotics here, methadone, tramadol, morphine, and so forth. This is big no. And then as we move down the list, you not that you absolutely cannot give oxycodone, but you have to be very, very careful. I wouldn't do fentanyl, methadone. Be careful with the tramadol and so forth if the patient really need it. They can have NSAIDs, they can have a Tylenol, ibuprofen, and so forth. What will happen is with these medications, they will have a hypertensive crisis, so very deadly, can be deadly hypertension. Um, and there are some food items that they have to be very, very careful and sometimes avoid it. The concept is that any food that is rich in tyramine needs to be avoided. When we eat food such as a cheese, salami, avocados, and so forth, they have a tyramine in it, and then you need monoamine oxidase enzyme to metabolize this. And on any given day we are able to metabolize, but today because you're taking these medications called monoamine oxidase inhibitors, you're actually blocking your enzyme, so therefore you won't be able to process this, and that will cause a hypertensive crisis. So the patient teaching will be avoid cheese. Just to give you idea, you can have up to, let's say, 6 milligram of a tyramine, even if you are taking MOI's drugs. But if one slice of Swiss cheese has almost a 2 milligram of tyramine in it, and who eats just one slice of cheese, right? Who eats just one salami, and then and so forth. The point here is you have to be very, very careful. So if the patient has a plan to go for wine tasting or Italian restaurant, so that requires a lot of patient teaching, right? Stage is set for them. So that's why these medications are not a first line treatment. It requires a lot of commitment and lifestyle modification. So this slide is very important from exam standpoint of view. So here's a visual for you to remember. And I know I talked about a hypertensive crisis, but what is it? Well, all of a sudden your blood pressure is high, systolic blood pressure more than 180 and diastolic more than 120. And any drug that will inhibit the breakdown of monoamines, such as monoamine, MAOIs inhibitors, can do that. And it happens when you take these medications. Patient is on these medications and they take tyramine-rich food along with the drug. And I just talked about this. And these are the presentation: hypertension, emergency, headache, dizziness, and so forth. It may result in retinopathy. So the treatment for hypertensive crisis is phentolamine. What will happen is when you take the medication, and the way it works, it actually will block alpha. It acts actually alpha blocker, if you will. So it will cause a vasodilation, so decrease blood pressure that way by working on the alpha receptors.
Now let's go over a few miscellaneous options. I have 3 drugs in front of me. We'll start off with first one, Wellbutrin, bupropion. Now the mechanism of action of this drug is different than SSRI and then SNRIs and so forth. So instead of dealing with serotonin, we have a dopamine now, and of course norepinephrine. Remember, we talked about this concept that even though the main key player with the depression is a low level of serotonin, but we believe it's overall imbalance of neurotransmitters, right? Norepinephrine, dopamine, and serotonin, and so forth. And that explains how and why SSRI works for most of the patients, but not for all of the patients, right? And sometimes you see that one drug works very well for this client, but then a different drug works very well for the other client, and that tells you that we are dealing with different types of imbalance within the neurotransmitter chemistry, if you will, right? Okay, so another interesting thing about Wellbutrin is because it increases your dopamine level by inhibiting the reuptake. When you have a client who's dealing with some kind of substance use disorder, let's say smoking, and the issue with substance use or for anything is we keep doing the same thing, whether if it's smoking or doing any other drugs or maybe exercise or whatever the deal is. We keep doing that because we like that. We feel good because we get a pleasure out of that, and dopamine is responsible for that, right? So we are dependent on that dopamine. So what do we do when you have a client who need some help with nicotine addictive to mitigate their craving? We can give Wellbutrin. So when the medication kicks in, medication will not allow dopamine to reuptake, so you have increased concentration of dopamine in the synaptic cleft here, and that's all you need sometimes to help with that craving. So that's a wonderful concept. Another good thing about this drug is that this is not abusable, so patients do not become addicted to it, right? So that's a good thing. One side note and important note is that this medication is a generally activating or stimulating drug. So that means if the drug is activating, we cannot give this medication to someone who has anxiety disorder along with the depression, right? So it's a client who's anxious should not be on this medication because it's going to further increase dopamine level and norepinephrine level, and that's not a good thing. So this drug is for a vegetative form of depression, somebody who's very, very calm, and we want to give them increase the dopamine or norepinephrine level. Not a drug for hot flashes, because this does not increase the serotonin. Remember, in previous slides we talked about Paxil, that we give Paxil to support female patients with hot flashes and so forth, because Paxil will increase serotonin activity. This medication doesn't. Okay, now if you didn't know already, the pathophysiology of hot flashes is that you have a decreased level of serotonin and increase noradrenergic levels. They're believed to be the pathophysiology, so therefore this medication will not help. All right, now the second very interesting drug is a Remeron or mirtazapine. Now I prescribe this medication a lot, actually, especially in the nursing home setting. So what happened is with this drug, we have two main issues or side effects. And number one is this medication is very sedating. So sedation is a problem. And second problem is increased appetite or increased weight gain, you can say. So if you have a client, let's see. Okay, so sedation and weight gain is a problem. Now, even though these two things are the side effect, but sometimes we can use this side effect in our favor. So if you have a client, let's say, I don't know, 65-year-old, male, well, let's do female this time. I think I gave enough examples with the male patients. Okay. All right, so 65-year-old female, with a depression disorder, and she's reporting that she can't sleep, she can't eat, she has no appetite, she's losing weight. Honestly, that's my very common scenarios in the nursing home. I get a phone call from a dietitian that my patient is losing weight, it's a significant weight loss, and I get a phone call from social service department, patient is reporting that she can't sleep, and nursing is also calling me. So anyways, when I make rounds, interview the patient, talk to the family and staff, and I usually start these patients on Remeron or mirtazapine after we have tried a non-pharmacological interventions, let's say. So I'll start, I don't know, like a 7.5 milligram of mirtazapine QHS at bedtime, because I really need that sedation as a benefit at this time, right? So we'll give a patient teaching that, hey, it may cause falls, be careful, call for help at nighttime, I don't want you to break your hip, and we'll keep an eye on the number of hours you sleep, and we also keep an eye on the weekly weights. And then within a few weeks or so, a couple of weeks, the numbers improve very beautifully. You see weight gain, you see overall change in their mood. And if needed, I might increase from 7.5 to maybe 15 milligram QHS, or maybe 45 milligram a day is the max. So anyways, good medication, I use that a lot, and also taper them off very slowly after several months. All right, well, the next medication is trazodone. Now, trazodone is also a very interesting antidepressant medication that carries a side effect of sedation as well. Now, the issue with trazodone is that to treat depression, to use this as an antidepressant medication, we need to take this medication at least BID to TID. Because this medication has a very short half-life, so it requires multiple doses, and it can be sedating. So can you imagine taking this medication throughout the day to treat a depression, and you're sedated, you can't do anything, you can't do activity of daily living? That's not good. So I personally do not prescribe this or use this medication from a depression standpoint of view, but we take advantage of sedation and we prescribe trazodone, maybe like a 25 milligram or so at night time to help with insomnia and sometimes maybe mild anxiety. That usually is the like a residual symptom of depression. I think of these medications as an augment to, you have a patient on SSRI, and then we can add these medication to help with insomnia maybe at night time. Even with Wellbutrin, I see that excellent choice to treat your residual symptoms. But be careful, if the patient has a history of seizures, you have to be very, very careful with Wellbutrin. Okay, so let's talk about another very important concept called treatment-resistant depression. Well, this refers to a situation when you have a patient who failed to respond to at least 2 adequate trials of antidepressant medication from 2 different drugs, or 2 different classification, I should say. And these patients, they remain symptomatic, severely depressed, despite trying the first line treatment, second line, and so forth. For example, they have tried SSRIs and maybe got augmented with SNRIs or TCAs or even ECT, and they still have symptoms. Now, so what can we do for these patients? Well, ketamine is one of the most promising agent now on the market. We know the role of ketamine for anesthesia and so forth, but for treatment in depression, what we know so far is that it seems to work on glutamate. So this drug is classified as NMDA receptor antagonist. So what happened is ketamine blocks the NMD receptor on GABA, recall that GABA is a inhibitory neurotransmitter. It will actually shut down or slow down or inhibit the activity, whereas the glutamate is excitatory, right? So you actually want to increase the concentration of a glutamate. That's what we want in the setting of depression. And too much GABA is a bad thing. So, and that actually explains that why some patients do not respond very well to SSRIs or other medications, because then the GABA kicks in, and GABA will inhibit the activity and doesn't help with the depression symptoms. Now, ketamine actually blocks that step. Ketamine binds here at a GABA receptors, and what happens is then you have increase a level of glutamate, and that's what you want. That's a good thing. Now, when you have increased level of a glutamate, it actually activates AMPA receptors, and AMPA receptors will further increase or lead to the BDNF release, and that will cause neurogenesis or plasticity, and that's a good thing. Remember, we thought that a brain, back in the days, we thought a brain is just one solid rigid organ, but that's not the case. We now know that we can actually make changes. The brain is actually plastic. So neurogenesis or plasticity is a good thing, especially in the areas like prefrontal cortex or hippocampus. So in simpler terms, you can say that ketamine helps the brain to form new, healthier connections, and that's incredibly important in the treatment of depression, where those neural circuits can be underactive or dysfunctional, right? Now, what's remarkable about ketamine is that how fast acting this can be, especially for some patients. They report significant mood changes within few hours or days, especially if you have a client with acute suicidal ideations. So that's a huge shift from traditional antidepressant such as SSRIs, SNRIs that I said it takes several weeks or months, right? So what happened is when we give IV ketamine, IV racemic ketamine, or intranasal form is also available as S-ketamine under the brand name of Spravato, which is FDA approved for this type of patients. So the medication kicks in if this is the time, and on the x-axis, if you have a client who was taking maybe, let's say, SSRI or SNRI, there's a slow growth, and the curve goes something like this. However, with the ketamine, you actually start all the way. It can actually jump, but the problem is actually from ketamine, even though it starts at higher, but it actually wear off very quickly. So that is the limitation. So in the beginning, you need the medication, for several weeks or so. So that is the problem. Now the another issue with ketamine is increased blood pressure issues. So these patients needs to be monitored, for several hours when they get the treatment. But overall, I think it's a very promising treatment, and I have personally heard good stories, outcomes from patients or their family. Needless to say, this medication has to be certified, has to be given by somebody who's certified in healthcare settings, like a provider, practitioners, and so forth. So it's not something that they can take at home. And long-term efficacy and safety for these drugs is still being studied, and we'll see what happens in the future. All right. Well, we just wrapped up a part 1 of the lecture on unipolar depression, I know it's a kind of a long lecture. Well, I don't know about you guys, but I am enjoying it. I'm having so much fun, maybe a little too much. So if you are starting to feel a little tired, now's the perfect time to pause and take a quick bio break. Grab a cup of coffee or snack, maybe question your life choices, whatever works. And when you are back, we'll dive into part two and take a deep dive into bipolar disorder. So please go on, take that well-deserved break, and I'll see you shortly.